A lot of the veterans and adults in general are not aware what an advance directive is and how it may help them and their families. And so we were brainstorming about how we might be able to better efficiently get that message out, and we came up with the idea of doing it in groups. And since then, we've been able to develop it with veteran feedback, veteran focus groups, asking veterans to help us, what's the best way to interact with you about this topic? So we've been able to come up with a program that's very satisfactory to veterans and that allows a discussion to occur to talk about, have you ever thought about this? Have you ever had an experience of making a decision for someone else? And through that process, they're able to actually engage and think about what it might be like for them if they were ever in a situation where they could not speak for themselves. Who would they trust to make decisions for them? What would they want that person to know and be prepared to do if they were ever in that situation? And another thing that we emphasize, it's not just about end of life. This durable power of attorney for healthcare, which is part of an advance directive, allows someone to, if it's a surgery, or even if a veteran's just very sick because and are expected to recover, but for a period of time, cannot make decisions for themselves. And so we, as a healthcare provider, I want to know who this veteran trusts, and I want to provide the care that is consistent with who they are as a person. And this allows us to engage veterans in this discussion, and because doing it as a group, we have more time, we're able to get into a pretty detailed discussion about how this might benefit them and their families.
It's ironic that you've ended up with a program that's based in doing it in a group rather than doing it individually, but it must be easier for the veterans to talk early on in a group than it would be if they were just an individual veteran and a nurse or a practitioner. Is that right?
Yes, sir. What we hear from the veterans is that discussing this as a group is a little bit less intimidating. A one-on-one discussion, you pretty much have to say something, but veterans feel that they can come to the group and they don't have to say something if they don't want to. The other thing that we hear time and time again is, I heard something from another veteran that I don't think I would have thought of myself. And so that's very beneficial to them to hear what their peers have to say and what their peers think about this process. We've also been told multiple times, you need to be doing this with every veteran. You shouldn't have such a small program. We want you doing this with everyone.
We hear a lot of problems at the VA and this and that, but it is good to sit back and talk about some of the successes. And the good news is that there really are many of them, and we certainly appreciate you being here, Dr. Garner and Mr. Bryant, the entire panel, but especially you all telling us about some of these things. Dr. Garner, your reputation in Little Rock is excellent, and we just appreciate, besides your innovation ability, your ability also to take care of people in a very, very caring, very excellent way. You've described, what you've done and things, your idea and things. Tell us if you see any problems with the national rollout of that.
I think it'll be fairly easy, as I hope that I adequately stated that most of these groups are held by not physicians because we want physicians taking care of veterans and access issues. These were not designed to be led by physicians. Social workers, nurses, chaplains, psychologists, many different health professionals run these groups after their training with us. So we know that different VAs are variable, and so we are going to have to be flexible as how we roll this out so that we get the personnel and the staff and have the staff to be able to do this. So that's one of the things that we will be working diligently with multiple different service lines around the country to do. I think as far as just the veterans really love it. They tell us all the time that they want this information. They like being proactive and people coming and telling them what are their rights and what are the opportunities for them to make sure that they take care of themselves and their families. So that's the biggest issue, is that many different VAs are different, and so we're going to have to be flexible in how we roll this out.
With the veterans communicating that they like the group setting, have you thought about any other areas that the group setting would be helpful in regard to?
Well, I think there are a lot of complex topics where a veteran could benefit from having a longer discussion that sometimes can occur in a short period of time. And we do see a lot of groups in the VA, like there are some diabetes groups, there are PTSD groups, there are other groups, and we think that those could be expanded with some of the other topics that are kind of complex, that need a little bit more time than you can get in a traditional appointment.
Right. Dr. Clancy, you looked like you wanted to jump in on that. Have you got any other thoughts on that?
No, I think I was just very positive about her
No, it's
response. Many of our facilities have group visits for PTSD and mental health and so
Right.
forth.
Tell me, in the sense of being a winner in the innovation efforts, is there the mechanism for you to stay involved? Will you stay involved? Are we going to do something with winners in the future? Go ahead.
Senator Boozman, yeah, absolutely. We really see our fellows in this program as being permanently involved in the improvement of the VA healthcare system, and Dr. Garner is really no exception. We are partnering her with an accountable executive in our central office in DC to come up with a comprehensive national scale plan for the advanced care planning best practice. We've already started that process. In fact, we had our first meeting several weeks ago. And by pairing the subject matter expert, Dr. Garner, with somebody with resources and accountability over professionals in social work across the entire country, we're going to start our national implementation very soon, where everybody at every facility who's owning the project is going to design the implementation as it best fits them. And so Dr. Garner is very flexible in saying it may be a social worker doing these classes, maybe a physician, maybe a nurse, but the whole point is that the outcome is achieved for the veteran.
That's great. So in regard to that, the metrics in place then, can you talk a little bit about specifically how are you going to judge the outcome of these things as time goes by?
Certainly. First and foremost, and I'll let Dr. Garner supplement this answer, but really we want to increase the rate of filed advance directives, just getting the service to as many people as possible, expanding that access, and really just to start the conversation. And so the more classes, the better. That means the more veterans are being exposed to it. And Dr. Garner, I don't know if you have more comments.
We actually have been working on a method of doing that where in the VA, there are certain note titles that you use that we can be tracked to say that a certain discussion was had. An example being advance directive is used when an advance directive is actually filled out. Or if you just had a discussion, you say advance directive discussion. With pairing that with the actual group clinic visits, we will able to see how many people had that group visit discussion about advance directives. And so we're actually working diligently right now to make sure that that's something that we can track and make sure we're getting the outcomes that really benefit the veterans.
Good. Very good. Thank you, Mr. Chairman.